Welcome everyone to today's webinar. I'm Anuja Vaidya with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. This session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it's my pleasure to start today's webinar by introducing our presenter. Phyllis Wotu-Six, Executive Vice President, Health System Solutions at Realtime Medical Systems, has over 35 years of healthcare experience in acute care, ambulatory care, and post-acute care. Phyllis has led the development of a preferred provider SNF network for Penn Medicine Lancaster General Health. In this network, she developed and implemented strategies that reduced total cost of care and readmissions while improving quality measures and patient outcomes. At this time, I am pleased to turn the floor over to Phyllis to begin today's presentation.
Thank you, Anuja. It's my pleasure to be here. Welcome, everyone. Happy to talk to you today. So today's topic is about interoperability between acute care and post-acute care. And I like to think of interoperability as a unicorn because it's something we all think might exist out there. We all hope exists out there. But when we're practicing in our everyday clinical lives, we don't always see it. And so one of the things that I think is really important as you begin to work with your post-acute network or continue to work there is looking for that elusive unicorn, interoperability. Even CMS understands that lack of data exchange really compromises patient outcomes and leads to higher costs. And so the quote you see on the screen is from actually CMS itself. And so we all know that we can do a better job of managing patient care with better interoperability. So what exists out there today in our healthcare world? When we look at how acute care and post-acute providers interact, KLAS Research just showed us that 66% of post-acute providers still share and access patient data via fax. So I actually thought faxes went out in like the 1990s, but apparently they still do exist. I think part of that has to do because there's certainly no unified EHR out there across either acute care or post-acute care. And as you can see on the screen, there's not a standard within either of those sectors of healthcare. And so how can we expect that there's interoperability when we all use different systems? And even those of us who use same systems like Epic, there's so many different ways to chart and place data that there's not a unified or standard approach. So, I think it's really interesting today that we can answer our phone on a watch, turn out lights, use a voice command, remotely start our car, but we can't transfer data back and forth for patients to be meaningful and to be able to use that in our day-to-day clinical lives. So I just thought that was an interesting point. So as you are working with your post-acute networks, and I think most post-acute networks have probably been developed in the last 5 to 7 years, primarily around ACO development and development of bundles. But before that, hospitals and health systems really did not bother or intervene or work with post-acute care. They really kind of had a hands-off approach. They weren't financially affected by the care that was given in those. But now as we talk about that, ACOs, bundles, hospitals, readmission reduction programs, post-acute care has become more and more important to the overall health system as well as to acute care health. And so we have plenty of reasons now to be able to want to work together. So we talked a little bit about interoperability, and we know it drives higher costs. Just to put some numbers to that, Medicare spend on readmissions is about $26 billion a year, and that data is probably from about 2017, 2018, so it's probably even a little more now. Medicare estimates that about $17 billion of that dollars are avoidable readmissions. And as we all know, there are the hospital readmission reduction program, which Medicare uses to, quote unquote, penalize hospitals for having higher readmission rates in those 6 identified categories. October 2019, there were $563 million taken out of hospital budgets because of that readmission penalty. And out of all the hospitals across the nation, 83% had a penalty around HARP. So that is a significant number. And we can see that having that interoperability could really reduce the number of readmissions and reduce the cost of care. So besides actual dollars, what else? Why is this important? The new conditions of participation around ADT information and feed, which will be put into effect in spring of 2021. It was to go in effect in the fall of 2020. However, COVID did push that back along with many other things. So we know that hospitals have to share ADT information with care partners, with payers, and actually with patients themselves, along with HIPAA changes that are also being discussed right now to have easier access to other providers in the care system, along with payers and patients. So interoperability is being pushed forward by CMS, and so we need to be able to respond to that. Of course, as I mentioned before, total cost of care, that $17 billion that could be reduced by reducing those avoidable readmissions. That's certainly important. And then the reason we're all here, patients and patients' outcomes. We really do, I know, as clinicians at heart, want to do the right things for our patient. And in order to do that, we should be able to get the information we need when we need it to be able to make those clinical decisions to improve the care processes. So if we're going to talk a little bit about managing a post-acute network, we need to talk about a few things. So typically early on in the ACO and bundle era, we looked at system metrics and we understood, what is our length of stay, what is our readmission rate, what are our quality metrics. And so we tried to improve on those metrics, but we didn't always try to drive care at the patient level. And I think that's one thing that we need to really consider as we're managing our post-acute network. If we drive care at the patient level, then we're going to see better care outcomes. Certainly system issues need to be addressed, and you can learn a lot by looking at your systems, but one patient at a time is who we treat every day. And so we need to make sure that those patients have the best outcomes we can. And so why should a hospital or health system, ACO, bundle manager, take responsibility for what happens in post-acute care? Well, I think we saw in the last 6 months or so, since COVID started, we understand that the sniff resource level certainly isn't what it is at our hospital or health system level on many fronts, from supplies to knowledge base, to actual staff members. So we need to be able to assist and take ownership of those outcomes when the SNFs are pushed to their limit. And not that hospitals and health systems weren't pushed to their limit, we all were. But the amount of resources that hospitals and health systems have far outweigh what you see on the SNF side. And then we talked a little bit about knowledge base. Really, the acute care system is the expert in case type care, so in care of our CHF or COPD. We really set the clinical standards about what happens there. And we don't always share that like we should with our SNF partners. So that's one thing to remember. It may be supplies or other things we share, but our knowledge base is very important to share as well. And then Impact Act, that requires us to be able to show how our post-acute partners are doing with quality so that when a patient makes a decision about where to go, what post-acute provider they should use, we are helping them with data that is meaningful from a quality perspective. And then, of course, our outcomes as a health system are now dramatically impacted by what happens in post-acute care, and not only at the SNF, but at the home health level, at the rehab hospital level. But we need to remember that if we're going to take some ownership of the outcomes, we need to help with the process as well. So how do we currently get interoperability not using a fax? Well, many things that we do, we use labor, and we use a lot of it. So it could be our own labor. We could be sending our case managers out or having them making phone calls. We outsource it to other companies who do that same thing, who either manage bundles or manage ACO patients. We don't typically get day-to-day information on those patients. What you see across the care landscape is weekly check-ins on how patients are doing. You don't always get the answer that you're looking for, and typically when you're not checking on that patient kind of day-to-day, something happens, they end up back in your ED, and I always found that once they got to my ED, they got admitted because they're complicated and it's very difficult to figure out plan of care in an ED that's full of other patients. So once they get back to the ED, they do get readmitted. Or we do ADT feeds, and there are national providers who do that, and that shows where the patients are going. You may get a small amount of clinical data. It's mostly diagnosis driven, and it's not data in real time to be able to intervene or act on what you're seeing at the patient level, and you don't even really know what's happening at the patient level. And then there are other bundle platforms out there that show you length of stay, and again, data from your diagnosis, but not necessarily clinical data as to what's happening day to day. So this is really what the standard is out there. And so getting that is not as effective as we certainly could be. So one of the things I want to talk about today is how do you manage SNF patients remotely? Well, certainly I think you need to start with a case management infrastructure. You need somebody to keep an eye on those patients. And as we know from Case Management 101, you want to focus your resources on your highest risk patients or your patients who are rising in risk. So being able to identify who those patients are is half the battle. You also want to intervene early when you see something going astray. When you see a clinical change, you want to be able to respond to that quickly and prevent that downward spiral and readmission. So your case managers need to have that clinical data in real time. You also want to worry about the transitions of care, both to and out of the SNF. So you want to make sure that when the patient is going into the SNF, the information that's going or following them is accurate and complete, as well as when the patient's being transitioned out of the SNF, you want to make sure that their next level of care, whether it's home or home with home care, has the information that is needed to be properly care for that patient or manage that patient, whether you're handing off to an ambulatory case management practice out of a PCP. Those transitions are very, very important. Obviously, you need to get the patient back to their PCP and in that network of care so that they're not out there on their own, and then when they have something happen, they just show up to the ED. So having that ambulatory network to manage those patients once they're discharged from the SNF is also very important. And then while the patient is there, you want to ensure that the access and oversight is still there by the clinical specialist, i.e. the physician who provided care in the hospital. So whether it's a cardiology issue or an orthopedic issue, you don't want to lose touch with that specialty, which is why they were driven to the hospital in the first place. So you want to kind of link that care from the acute care specialist to the sniff and make sure that the proper oversight is happening. And then one of the other things that we typically see is a lot of end-of-life issues where patients are coming into the hospital, going back to the skilled care, and really they are at end-of-life from their disease process and probably might benefit from palliative care from an approach, but no one really has that conversation. And so part of your case management platform should be able to identify patients who might benefit from palliative care instead of readmissions around that case type. Again, what you need to be able to manage these patients is you need to be able to see what's happening clinically, live data. So what was their blood pressure this morning? What's their weight if they're a CHF patient? You also need a system that can help alert or identify potential clinical issues. So if their weight is going up, is there an alert for that for a CHF patient? Or are you seeing edema being charted in the nurse's notes, but yet no one's putting the increasing weight and the edema, and then later the next shift, there's shortness of breath noted. No one's putting that all together. There's not one platform to look at that. Of course, we did talk about risk stratification. That is very, very important. You also need to have your acute care standards of care embedded in that process. So again, driving clinical outcomes based on specialty care, but translated into what happens at a sniff. That's a key tool that you can use to manage care remotely. Then when something goes wrong, understanding what that is from a root cause analysis perspective. So was it a system issue? Was there clinical signs that the staff didn't pick up on? Is there something that we missed when we transferred that patient to a facility? So looking at root cause analysis, as we all know, is a really good way to be able to understand our system issues. And then when you're doing that root cause analysis, are you seeing all of your CHF patients come back? Is that what you're seeing? Are you seeing pneumonia patients coming back? And if so, is there a trend there that you can identify and then put something into place to be able to manage that? So all of those pieces, I think, really help you manage that patient at the clinical level in that remote location. So the other thing I think that's really important when you want to have line of sight, you want to drive the care process improvements within your SNF network. So one, you want to have a clinical plan for those case types that you can. That drives care day to day with expected outcomes so everybody's clear on what should be happening each day. You should also have that for the patient at the patient level, because the patient needs to be invested in their care, and they also want to understand what's happening to me. How do I get better? How do I get out of there? So those clinical plans by case type, standardizing care in your network. You also need to have an estimated discharge date upon admission to the facility. So when you're setting that up, we typically have an onboarding meeting where the physical therapist, the nurse at the facility, the case manager from the acute care hospital calls in along with patient and family and understands what the goals of care are for this stay, what the patient needs to do to be able to move to the next level of care, and everybody is on that same page. And just having those understandings from the patient and family perspective, first of all, it puts them at ease to know what's going to happen next, but it also invests and engages them in their own care, and they know what they have to do to be able to move on, typically to home or to the next level of care. Of course, monitoring length of stay is very important also. We all know that we have standards out there for patients who should be not only for acute care, how many days in the hospital, but how many days they should be staying in a post-acute facility to manage that patient and get the right outcome and then get them to the next level of care. And we all know that with length of stay, that also relates to cost per case, so that's a very important thing. And then as you're doing all of those things, you may be able to identify that there are gaps in your care process. I'd like to give you an example here that happened in my network. We were very big on getting our fractured hip patients in the hospital up the night of surgery. They would stay there 3 days to have their qualifying Medicare stay, and then they would go to their skilled nursing facility for typically a 2-week stay to be able to improve their functional abilities. And so we expected from the hospital side that the patient would be getting out of bed because we'd already gotten them out of bed and started therapy. But we found that the patients weren't getting out of bed day 1 and 2 in the facility. And when we really looked at the root cause analysis, what we found is that we gave so many narcotics on the inpatient side that the patients developed urinary retention, and that limited their ability to be able to rehab in the facility, and it set us back about a day to a day and a half. And so when you look at the whole picture and understand the care process across different places of care, you can really put that together and improve. And one of the things our system did was we moved to IV Tylenol instead of using too many narcotics that adversely affected the patient outcome. So that's a way we're working together, highlighted a care gap or a process gap on the inpatient side. So how do we continue to drive process improvement? I think one of the most important things that you can do is have a solid discharge process within the sniff. So as you're getting the patient ready to be discharged from the sniff, you need to be able to make sure that they get back to their PCP. We know that patients that don't see their PCPs within 72 hours, 3 to 5 days, have a higher readmission rate back to the hospital. So that's critical because the patient then is able to understand what their instructions are and what they need to do go forward. I know that we all educate patients when they're transferred out to a SNF, when the SNF discharges them, but touching base with their PCP and reinforcing that really proves to be beneficial in reducing readmissions. Doing a follow-up phone call from the SNF, making sure that all the services that were ordered have happened. So did they get home health? Did they get their Meals on Wheels? And then obviously connecting them to those community services that will ensure that they're able to stay safely in their home and get the items and things that they need. I think also what to do in an emergency is always a good thing for the patient to know, because oftentimes they'll panic and call 911 immediately when something could have been handled differently. And then one of the other things you want to consider when you're working with your SNFs is having your SNFs let the patients know upon discharge that if they begin to fail or do poorly, they can typically go back to that SNF for additional care if needed, instead of returning to the hospital and having a readmission. So that's something we utilized in our network and made sure that patients who were discharged from SNF knew that they could do that. So another thing that you want to look at in your network is you want to understand your readmission rates. So root cause analysis, the why behind the readmission, is really an important piece to understanding and preventing further readmissions. Using the Interact 4 tool, which Interact is kind of a gold standard out there for care in post-acute settings, that they have a really great readmission or root cause analysis tool that helps you identify what happened. Did it happen on an off shift? Was it a physician who was covering? Was it a new nurse? What was actually going on there? When you look at your readmissions, it's also important to look at the timing of them from the length of stay in facilities on the post-acute side. So typically when you see a readmission in that 1 to 3 day period, that is most likely a transition of care error, meaning that the facility did not get what they needed to be able to care for that patient. Either they didn't know they needed wound vac, they were unable to get the highly specialized antibiotic because it's not available except to hospital pharmacies. If it's 4 to 7 days, typically the patient had a change in condition about what was happening. So they either developed something new or their condition worsened. And then when it's greater than 7 days, typically that's an issue that might have been prevented if it was identified earlier. So typically we ask our sniff partners to really look at the process of care and what happened with that. And then who or what was driving the patient back to an acute care setting. Oftentimes it might not be the patient, it might be the family, or it might be weekend or coverage staff or a physician who doesn't know the patient. So understanding all of those things can really help you improve process of care and outcomes related to that. So continuing with transparent data, utilizing clinical standards, clinical plans or standards of care and deploying them across your network. So sharing what you want to happen with that patient clinically with your sniff or post-acute partners is very important. It helps you monitor interval outcomes and know that the patient is progressing. It helps educate, and you want to standardize your education across your network so that every facility is using the same information to be able to educate, and it should be the same as what the hospital uses. So we're not confusing the patient and conflicting them. And I'll give you an example. For CHF, the AHA has a really nice red, yellow, green stoplight approach to patient education. The patient identifies, are they in the red, yellow, or green zone, and it tells them what to do if they are. So using those types of tools across your system is really helpful for patient outcomes as well as patient education. And then looking at your assessment guidelines, making sure that the correct assessments on these patients are being done at the regular outcomes that you need to have happen. So one of the big discussions in my network, because we focused on CHF, was the use of daily weights. And we had multiple discussions on why it's really difficult to do daily weights at a facility. You don't have the same scale. You have to wake the patient up early. Your staffing issues, those kind of things. But that is the one gold standard that we send patients home with in order to understand what their fluid status is. And so when we really explained that and told them, you don't have to do daily weights on everybody, but on these CHF patients who it is critical for, that's really important to be able to do that on that specific case type. And we were able to do that. And in fact, we worked together to get additional scales in the facility, and we asked the patient to also track their own weight because they were going to have to do that when they went home. So again, there's that patient engagement in the care process. And then with that clinical plan, looking at what needs to be achieved on a day-to-day basis. So today it might be education. Tomorrow it might be making sure that their daily weights are happening. It might be walking in the halls twice a day, but having those outcomes clear so that all of the care team understands and the patient understands really can drive your clinical performance. So one other thing I think that we found out during COVID was understanding patient flow on the post-acute care side. So first of all, understanding who has capacity in your network at a moment instead of calling, waiting for calls back. Do you have a male bed? Do you have a female bed? Having that data at your fingertips remotely in a platform is extremely useful. And then we also needed to understand who would take patients with COVID or other disease processes. So knowing that in this facility, they already had several COVID patients, we knew that they would take COVID patients. And so that was really important. And then using all of that to drive discharge process so that you can free up additional beds when you need them, kind of links together to that patient flow piece. Now let's talk a little bit more about risk stratification. What makes a patient high risk in a SNF? I think there's 4 key things. So first of all, I said earlier that patients who are in the facility for that 1 to 3 day length of stay, they're at higher risk because they're just getting settled in. We have that transition of care, so that we know recency of admission is important to score as a risk stratifier. Obviously, changing clinical picture, vital sign changes, changes in how the patient's feeling, understanding what that picture is, that also helps with risk stratification. And then what is their history around readmission? So this is very similar to what you see LACE doing. It's just a little bit different with the timing around admission to the facility. And of course, their comorbid diagnosis. Are they somebody who just has a history of sepsis, or they have sepsis, CHF, pneumonia, and other high-risk diagnoses? So understanding risk, not just at the system level, but at the individual level, and being able to intervene on that really helps you manage your network and your patients much better. And then what do you do? How do you mitigate that risk? And really, that's by identifying those risks early on. So early symptom identification, being alerted to understanding what are those comorbid conditions you need to look out for. Are there changes in weight, fluid intake, bowel movement, vital signs, pain intensity, and risk of infection? All of those things, if you identify early, you can intervene and prevent not only a poor patient outcome, but a readmission outcome for your system. So understanding those risks and being alerted to them early, that, along with your case management platform, can really prevent those poor outcomes that we oftentimes see. So I want to talk about a case study and show you how this system was able to manage their readmissions and manage their high-risk patients with a platform from Realtime. So the challenge at this acute care provider, they had a network of post-acute facilities. They had 10 facilities. They averaged between 3,000 and 4,000 sniff discharges a year. They knew from their ACO data that they were overutilization of post-acute days, meaning their length of stay was much higher than other regional and national averages, was accountable to their ACO, and they had to have certain quality and cost containment actions. And then the impact of readmission rates and how that affected total cost of care and how it actually affected patient outcomes. So those were the things that this system wanted to focus on. It's a 4-hospital system, 800 beds with an ACO. And so what they did is they used the Realtime platform to get that post-acute care interoperability, to have that line of sight into the data that could make a difference with the patient's care. And so they were able to monitor live data from the Smiths EHR. They were able to see vital sign changes. They were able to see weight gains. They were able to work with their Smith partners to drive standards of care. They were able to identify patients who were at risk and keep an eye on them. And they were able to deploy those clinical standards that we talked about, both from a clinical plan perspective and from a discharge standard perspective. And then they were able to implement that in a very short period of time at a very relatively low cost. We know that oftentimes EHR integrations take hundreds of thousands of dollars, if not millions at times. And so finding a solution that was easily adaptable and repeatable was critical for this ACO. I want to show you some of the results that this ACO and health system achieved. When they started this in 2016, their readmission rate was about 18%, And actually, for that time period, that was well below national standards. So national readmission rate at that time was in the high 20s to low 30% range. Now it's still around 23 to 24% that comes from CMS. Within 1 year, by having case managers look at the data on the platform and work together with their SNF partners, they were able to reduce their readmission rate by about 50 to 60%. And they have maintained that rate and recently fell, as recently as this past fiscal year, fell under 8%. So they're able to keep the patients who shouldn't be coming back to the hospital out of the hospital. They were also able to bend their cost curve by decreasing length of stay and standardizing what those lengths of stay should look like, by standardizing what happens on a day-to-day basis, by using those clinical plans to be able to monitor care and progress care. And so that length of stay reduction resulted in that $4 million plus cost curve bend. And so it was very clear that using a system to partner with their SNFs to be able to see what was happening, act early and intervene, and then standardize what was happening with the patient really paid off for this ACO. So that unicorn I talked about in the very beginning, it is here. You can have that type of a relationship with your SNF without that big cost of integration, without years of development, and you can see it on one platform, even though we talked about that there are many EHRs out there on the acute care and the post-acute side. So being able to access all of that information quickly, easily, and seeing it in the same way, and then using that information to be able to customize what your interventions are by case type. So when you see a clinical alert, you're able to have a response that you want the staff at the facility to be able to do to drive care in the right way. You're able to look and see what happened with those patients that were readmitted and start to complete that root cause analysis, as well as you're providing your SNFs with the opportunity to improve their care, improve their outcomes, which everybody wants to do, and then work together with you as your partner. And so I think one of the things we felt out of this partnership is that we gained insight into practices that we should change on our healthcare or health system side, as well as understanding how to help drive care on the post-acute side. So thank you very much. That's the end of my presentation. And Anuja, I think, will be coming back on.
Thank you so much, Phyllis. That was a fantastic presentation. We will now begin today's question and answer session. Please submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We will try to get through as many questions as we have time for. So let's jump into our first question here. One audience member asks, where would one find the SNF LOS with care pathways for disease specific?
So there are plenty of platforms out there that have that. Advisory Board has that. I believe Point Right also has that. So there are providers of that type of data out there by case type.
Fantastic. Thank you so much for that information, Phyllis. Our next question here is, do you have any data on improved outcomes with family involvement?
So I will say one of the things that we did, we had patients and families who would often clamor to come back to the hospital because the type of care they received in the hospital is obviously different than what they received in their SNF. And we did a baseline satisfaction survey, and then we implemented that onboarding strategy that we talked about, and we found that the level of satisfaction dramatically improved when the patient and family had that initial onboarding meeting and being able to understand what their goals of care were and what they actually needed to do and how the sniff care was different than being in a hospital, and that the goals of each of those care settings was very different. So I can't say that the family involvement was the only thing that improved that satisfaction level, but we found that when we clearly articulated to the patient and family what was happening, what would happen next, and what they needed to do, their satisfaction level rose. We had much less issues around people wanting to return to the hospital for care, and so it really did make an improvement in our outcomes.
Very interesting. Thank you for providing all those details. So our next question comes in from an audience member who is wondering, did they implement any RPM to help monitor the care?
So yes, using the platform to be able to do that really did help with those outcomes. So yeah.
Fantastic. So here's an interesting question. So why do Smiths want to share their data?
So interestingly enough, they really want to do the right thing for their patients. They are somewhat reluctant at times to share data because they think they're going to be chastised or penalized for sharing that data. What you need to do when you're doing this is make sure that everyone at the table understands that this is about patient outcomes. Because if you appeal to their nature, they want to do the right thing for their patients, just like staff members on the acute care side want to do the right thing, so do SNF. And so once you appeal to that nature and you show that coordination of care is better for patient outcomes and that we all gain by that, that is very helpful. I think with bundles leading the way, that has changed some of the outlook that you see from post-acute providers. They understand that CMS is looking at care differently and that it's not as segmented. So those attitudes, I think, are starting to change.
Got it. Thank you so much, Phyllis. So another audience member wants to know, what opportunities do you see with regards to using technology to enhance service delivery in the post-acute space?
So I think the technology that we're talking about today, that ability to see live clinical data, I think that's really important to be able to drive not only service delivery, but outcome delivery in that. And so SNFs are becoming more and more technology savvy. And so I'll use another example here. Seeing telehealth patients, if you use the platform from Realtime to identify people who might be having an issue or a clinical problem, and certainly you can call your physician and the attending who's on and have them seen, but oftentimes those things happen on nights and weekends. And so using telehealth in addition to the platform can really help you have somebody assess that patient quickly from a physician or provider standpoint and be able to respond and manage that patient effectively in place at the facility. So I see a lot of opportunities around increasing technology in the post-acute side.
That's great. Thank you so much for those insights. So our next question is, are SNFs part of bundles and ACOs?
So SNFs certainly are part of bundles because the care that you're doing is responsible for 90 days. So when a patient's discharged to the SNF, that's certainly in that 90-day period. And so absolutely, they are in that that ACO, or excuse me, in that bundle. And from an ACO perspective, you're really looking at total cost of care. And so you know that your ACO members go to Smiths. They are typically in a clinically integrated network, or a SIN, within an ACO. And so I think it's really important to understand who your partners are and to choose them wisely. You want to choose people who want to be technology savvy and who want to do the right thing for the patient, and who have agree to share knowledge and work with you at that patient level as well. So yes, they are part of bundles and they are part of ACOs.
Great, thanks for all that information. So how did the larger ACOs support the effort?
Excuse me. So in this, there are many ways to do that. So depending on what type of ACO you are, if you're a Medicare shared savings, is there a way, if you're achieving shared savings, to share that with your post-acute providers if they perform well? That's certainly a way to do that. The platform that I talked about, Realtime, in some networks, the hospitals actually just pay for that and allow the SNF to use the platform as well to see those same clinical alerts and drive those same outcomes. As long as you're improving that care and working together, I think that's really an important piece of that. And then making sure that you in some way reward your partners. It doesn't always have to be monetarily. It could be educationally. It could be with support on devices or PPE or other things, but making sure that you're a good partner with your post-acute partners, I think, is very important.
Definitely a key point there. So another audience member asks, you discussed the positives associated with the solution, but could you please discuss some of the challenges you encountered in the case study at the four-system hospital?
Oh, sure, absolutely. So before we had this platform, we argued constantly about data. So the SNF brought their data to the table. I brought data to the table from the hospital perspective, from the claims data. We could never match the data. So one set of data would say one thing, another set of data would say something else, and we really weren't able to come to a consensus until we found a platform that operated off of the same data set, and that was out of the SNF EHR. So pulling all that data and having everybody see the same data at the same time really improved how we worked with our partners. Because before that, we just didn't know what data to believe or what data was actually showing. So that was a really challenging part. And when we first formed our network, it took us about a year just to figure that out, that we needed to be talking about the same data. And then, of course, you know, there certainly were other challenges. One of the challenges that we faced is staff turnover at SNFs. So we had to really have a flexible educational program to bring people up to speed quickly on clinical plans. And so that was a challenge when we first started to roll out clinical plans. We did a large educational session with the specialists, with case managers, and then with the staff at the facility. Well, obviously, when you lose a third to a half of your staff in a year, doing those all the time really became challenging. And so we actually utilized a skill set test to be able to help people understand at the facility on a biannual basis what types of things they needed to do and perform for getting the right type of clinical information. So we partnered around doing that skill sessions, which really helped us improve the care that was delivered at the SNF.
Got it. Thank you so much, Phyllis. So we have another question coming in here from an audience member who's wondering, besides SNF, Have you done any work with other PACs such as rehab, home care, or LTAH?
So we have this platform really only pulls information from the Smiths EHR. We do not pull information from LTACs or hospital rehabs or home care. And part of that on the home care side, because I think that's a natural progression. We all want to see more data on our patients at home, particularly with home care. But the amount of touches that you see from home care are, not over a sustained period of time, meaning that someone's not there every day gathering data on the patient. It's really hard to understand what that data means at any given time because it's so infrequent. And so we haven't done that, but at the network level, we certainly did. And not only did we roll out clinical plans to our SNFs, we also rolled that out to our home cares. We didn't have an LTAC within the community, so we didn't have a lot with that, but we did also work with our local rehab hospital to make sure that they were following the same standards of care. And we actually brought that big group all together to talk about those challenges because rehab hospitals also discharge people to SNF and to home with home care. So we did take a larger approach than just with a SNF.
Got it. Thank you for that great question and informative response. So that is all the time that we have for today. Phyllis, I'd like to turn the floor over to you one more time to see if you have any closing thoughts that you'd like to share.
Yeah, sure. I do have just one or two. I think that we all know that we are judged on outcomes, patient outcomes, financial outcomes, and that in this world that's looking at care not as just in a particular setting, but throughout the continuum, we really need to deploy our standards across our network and really manage care, take a different approach and manage care outside of our four walls. And to do that, you really need to have data and interoperability to be able to perform those functions at the level we need to make system changes that improve that care and outcome. So I think for ACOs, health systems that need to manage care related to readmissions and bundles, interoperability is key to obtaining success and better system results. So I think that's a very important thing.
Absolutely. Thank you for giving us that final key thought there, Phyllis, and thank you for your excellent presentation. I'd also like to thank Realtime Medical Systems for sponsoring today's webinar. Enjoy the rest of your day, and we look forward to having you join us for future webinars.